let's get something set up.
This meeting is being recorded.
Separately from this, and talk about sort of the issues that we talked about, like the messaging that you would like us to carry, up to DC and around to the various disciplines and all that kind of stuff too. Because we would love to have that mission. We think with the changes going on in prostate cancer treatment, right, with the increase in technology applications, with the theranostics and the PSMAs and the requirement for all of these machines, right? I mean, you got to have these machines to make the stuff work. Yes. And, hopefully the leadership will start realizing that, right? I mean, they'll start understanding what the heck all these things are.
And theranostics is something radiation oncologists can do. It's basically, we probably are more likely to get the radiation oncologist embracing it in a lot of these sites rather than the nuclear medicine, because a lot of them are not full-time.
Yeah.
So, yeah, it's definitely worth looking into.
Okay. And, yeah. Well, we should understand. We just need to we as an organization, and you'll see that we're growing by the month, and guys are starting to understand this, that we need to get in earlier. We need to do the earlier detection, but part of that is coming with, this implementation of this new technology and these new devices. And so we need to get your messaging to take this forward. Right?
And that, like this talk, I focus very much on what you had said in your email, but really we could probably have a separate talk alone just on active surveillance and decision-making for that, and we'd be happy to have someone give that talk. And also the radiogenomics that are coming out. We actually have a what's called an evidence synthesis project going on within the VA for them to synthesize all the evidence that's out there for the genomic testing to see what its advantage is, to see does it really something people should get. So we would be able to present the results of that as well. So, awesome. We're happy to speak at any one of these, and they're big topics. So, in order to have people really have the chance to understand them, or to do webinars like in between your monthly meeting, we're happy to facilitate those as well.
That's perfect. Yeah, we'd love to. And thank you for offering that. We will definitely put something together. We had some talks with some people in DC today. We have a kind of a prototype group going on in DC at the VA there that are doing in person now support groups in the basement of the VA. And they've had two of them now, and they went off, I guess, very well. I mean, Harry DePolar was the one running it, so it was very good.
Yeah, we've had in New Jersey. We started a prostate support group probably 10 years ago with a clinical psychologist interested in oncology, and that's always been a huge success, in person or virtual.
Okay. So all right.
So will I get started or?
Yeah, let's. We'll give them like 30 more seconds, and then we can get started. And if
welcome to those who've joined.
Yeah, and I think everybody kind of knows the rules. I see a lot of familiar faces. A couple guys still joining in. I want to say thanks to everybody. Happy June. Can you believe it? It's going to be the 4th of July. Where did this year go? So. I mean, it's so we're recording, so everybody is aware. And if you're not speaking, we ask you to keep it on mute. Just helps with the background noise. Because we've been just a little bit of admin, and then I'll turn it over to Dr. Kelly. But we have all of the sessions, the 50 vets and 50 state sessions. It's our once a month call on a specific topic, and they're all now being posted on our website and for use. And we'll put links on there in social media so that everybody can get a kind of a heads up. Or if you miss something, please know that it'll be posted on the website and you can come back and get it. We have basically our admin for next month is we have two issues: the VFW National Convention and also the VHA Healthcare Summit in Washington D.C. on the 19th and 20th. And Dr. Kelly, I don't know if you're going to be there or not, but there's some of the leadership are talking about various topics in the that are going on in the VA. It's kind of an expensive trade event to go to, but somebody will be there. We'll also be attending the VFW National Convention with prostate education, or PCEC, Prostate Conditions Education Council, Winnie Poag and her group, to help with taking, we'll actually be doing screening there, taking blood from volunteers and doing PSA screening. So I want to thank everybody for that. The two other big events for the rest of the year are Miramar Air Show, 23 to 25 September. We have a chalet there, and we'll be hosting everyone at that event. And then we have our gala, our fundraising gala in New York City on the 11th of November, which is Veterans Day. It's on board the USS Intrepid, and you'll all have invites, and we expect to see everybody there in your best attire. It'll be a black tie function, and the next day we're working with the police department and the fire department to actually have a men's health fair on the pier inside one of the pier venues there. It'll be free to everybody, so no cost to any man that wants to come into the health fair on the next morning. So with that, I got an update. I got a quick update from Sarah in Dr. Dunn's office, Congressman Dunn's office, about HR 4880 and the Senate 2720. She asked me that if we don't see movement on it within the next 10 days, or after the holiday, 10 days after the holiday, that she's going to ask us to put together a letter writing campaign to push for a vote on those two bills. And we'll make a specific request to Ms. Pelosi, who's here in California. So we've got some people in San Francisco that can push on her directly as constituents, and we'll ask for a vote on those two bills. They've both been introduced on the floor of both the House and the Senate, and there's been no pushback to this point. And we need to put a little bit of pressure on to get those through, because it's all about prostate cancer clinical pathway in the VA, and also some additional research money. And the clinical pathway is, we think, critical to standardizing care and the process of dealing with prostate cancer in the VA. And I think you'll hear that from Dr. Kelly today, is that while most vets see some sort of standardized care, it's probably not consistent. We know it's not consistent across the VA, and we're missing out on a lot of opportunities to treat guys with early intervention, and also with radiation type of care, because as we'll all find out, there's a limited number of sites inside the VA that are actually treating with radiation, and they're doing a great job, but they need some more help. And we'll listen to Dr. Kelly, and with that, I'm going to stop, and I'm going to introduce our very friendly guest. She's been a friend of mine for years, since I was first diagnosed with the cancer. She's one of the first people I met in the VA, and I have to say that our friendship has been, we haven't spent enough time together, and I want to change that. But she's been a great supporter of mine and ours, and so I want to welcome the head of. She's actually the chief of radiation oncology inside the Veterans Health Administration. It's Dr. Maria Kelly. So, Dr. Kelly, floor is yours.
Thank you very much. I would just say, following up on your comments, it's not all about even equipment and all the personnel. I think if everyone had a navigator on site for prostate cancer, that would be a huge difference, because if they're tracking the positive biopsy or the elevated PSA, these women will run with the ball, or men, whoever. But if you have people that you give them their task, that's what they focus on, and then nobody slips through the cracks. Because we established that in New Jersey, again, about 10 years ago, and it made a huge difference in making sure that everyone got, because they stay on the person, and of course I've had people who don't want to be treated, but we try and keep persuading them. So, but they're a huge asset.
Can you connect me with the navigator group there at New Jersey?
I can, yeah. I can connect you with the woman who's been doing it most recently, Michelle.
Okay, that'd be
Okay.
great. We'll do that afterwards, but yeah, thank you.
So let me see if I can share my screen now, hopefully. Okay, so is everyone seeing the talk?
It's coming in, yeah.
Well, not if it says Fred Schneeman on it.
I'm here.
We don't see anything yet.
I'm here. I'm here.
That's not,
There we go. Oh, it was there.
oh, all right, let me see again. So I don't see it on my Zoom screen, so I have to have someone tell me that they have it.
It started. I think it just has to load in here. It was loading and then I think we clicked out of it.
Yeah, okay. So it should say radiation therapy and side effects for prostate cancer.
It is there and your name on the bottom. Yes.
Okay. All right, so let's get started then. So first I want to acknowledge Dr. Kishan, Dr. Solanki, and Dr. Obedian, because I really put this talk together with a lot of slides from their talks, plus some slides I had myself because the short turnaround time. So basically, how does radiation kill cancer? Cancer cells are defined by their ability to divide uncontrollably. So the brakes that normally stop cells from getting out of control are missing in a cancer cell. The radiation causes significant damage to cellular DNA, which the cancer cells are then unable to repair. So when they try to divide with the damaged DNA, they die. And that's the simple way it works. So radical prostatectomy. We recommend it for clinically localized disease, for patients with a life expectancy greater than 10 years. For better outcomes are done by high volume surgeons in high volume centers. So a lot of what you hear about nerve sparing, blah, 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 we should have robotics. It's all about the hands of the operator. So you don't want someone who does 10 of these a year. You want someone who's doing 1,000 a year or 500, whatever the numbers are in the urology specialty group, defining what is expertise. Robotic laparoscopic prostatectomy is less blood loss, shorter hospital stays, and possibly less side effects, again, in the hands of a competent, experienced person, because if they don't really know what they're doing in a cancer surgery, it's not the same as just shelling out the prostate for hypertrophy. Obviously, we're interested in getting all the cancer out. The benefits are that the pathology can all be reviewed. So if there are areas of higher grade that are missed in a biopsy, you're made aware of it, and also information about extracapsular extension. Of course, a lot of the extracapsular extension information can now be obtained with better imaging. It's one procedure. If it doesn't work, radiation is a very good backup treatment versus if radiation doesn't work, surgery is not a good backup. There's no bowel side effects, no risk of a second cancer due to treatment. But as you'll see later on, these are not big risks with radiation anyway. The side effects in surgery are urinary as far as incontinence, and I put the surgery in caps because the patients we've seen post-radical prostatectomy, they have really big problems usually with incontinence, which we don't see a lot of. We don't see incontinence really with radiation. We're talking about bladder irritation. Sexual surgery can have worse because if you cut the nerves, that's it, game over. The bowel is more likely with radiation, although again, newer techniques, this is not so much an issue, and a second cancer is a very rare situation. And of course, whether you're on surgery or radiation, you can have hormonal side effects if you're on androgen deprivation therapy. The thing is though, for somebody who's a young man, we are recommending that people should get both opinions, and we don't give the surgical opinion, but we don't think the surgeons should give the radiation opinion. And if a person is a good surgical candidate, we'll encourage them to do surgery. So radiation is a standard of care option for prostate cancer. There's two fundamentally different types of radiation: external beam, which EBRT, or brachytherapy, which is any form of implanted radiation. So external beam, protons, something that comes up all the time. I'm not going to spend much time on it. There's a theoretical physical advantage over X-rays. We do not recommend it in the VA, except in very limited circumstances and usually for diseases that are not prostate cancer. And the NCCN, which is the National Cancer Center network of guidelines in 2022 said there's no clear evidence supporting a benefit or a decrement to proton therapy over IMRT for either treatment efficacy or long-term toxicity. So a lot of the people pushing protons for prostate cancer, it's because they have an expensive piece of equipment, and the typical indications for protons, there's not enough volume of that type of cancer. So the way to be able to make up the volume is pick a common cancer, and the common cancer is prostate cancer. Now, we are, again, working with an evidence synthesis program to look at the latest literature on protons to see if we're going to change our directive, but right now we do not support proton therapy for prostate cancer in the VA. So these are the principles of external beam. It's high energy X-rays directed towards the prostate by a linear accelerator. They're not patients are not radioactive. There's no heating or burning involved. An external beam is completely non-invasive. And on the screen, the upper machine is called a Meridian Linac, or basically it's an MRI Linac. So the idea is that this machine will provide MRI imaging in addition to delivering radiation treatment. The machine below it is a Varian Linac, and that machine, if you see the two, I don't know if you can see the arrows when I point on it, but the two on either side of what's in the middle are wings, and those wings are to take CT images. So the imaging is CT as opposed to MRI. This on the left-hand side of the screen, I hope I have my right and left correct,
Yep.
But the one that's on an angle, that's an Electa machine. And the big difference to look at is the fact the Electa puts all its guts behind the wall. So it's just a flat surface. It's felt to be more pleasing to the patient, not less intimidating when they come into the room. The other machine is a Varian machine, and they keep all their guts underneath the plastic covers, and they're in front of the wall. Basically, both machines do the same thing from a patient point of view as far as killing cancer. Physicians have preferences and physicists, and it has to do with connectivity to other pieces of equipment. But from a patient perspective, they're identical with respect to outcome. This is the Accuray CyberKnife, and as you can see, it's like a gun pointed directly down on this model. That head will move in all different directions in order to target the prostate as the prostate moves around. So it is one method of delivering SBRT. It was invented before the modern technology that allowed you to achieve the same result with a linear accelerator. It is longer duration of treatment than doing this with a linear accelerator. But again, there are different advantages, and some of the CyberKnife advantages are probably more for the brain as opposed to the prostate. This then is called a RadExact, which is another Accuray product, and it is essentially what replaces the tomotherapy unit that was introduced around 2004. It is basically a linear accelerator built into a CT scanner, and it allows you to acquire CT images while you're delivering radiation. And it is similar to an MRI Linac in that both of them provide imaging that allows you to do adaptive radiotherapy, which means that you will change the volume you're treating as you go through treatment, reflecting maybe that the tumor is shrinking or there's less biologic activity showing a response, and that you might be able to reduce the dose as you go along to a smaller volume of tissue, thus adding more protection to your normal tissues. So when I started doing radiation in 1985 as a resident, this is basically what radiation therapy was. Two fields coming in from two opposite sides. And in this slide, the pink would be your prostate, and those two blue circles would be, for example, the femoral heads of your thigh bones. So you could come in front to back, or you could add another two fields and come in top. You go right to left, you could add another two fields and come in top to bottom. And the most conformal you could get would be to add some other fields coming in at angles. But at the end of the day, you are just manipulating squares. And you are still treating a lot more tissue than what you would want to treat. And this is also because there was no CT planning done at the time. It's just anatomically, you would say the prostate measures X number of centimeters above the pubic symphysis, so many centimeters below. It's usually this wide. That's the size of the field, and then we've got to put 2 centimeters around that to allow for motion. Even though back then nobody thought the prostate moved very much, so you really felt like there was no way you were going to miss it, and you'd hardly miss it like this anyway because you were treating a huge field. Then we got conformal. So conformal meant that instead of those 2 blue circles being in the field, now the field is just the outline around the tumor, and it's exactly shaped to the tumor. And that was conformal isodose distribution, and that was facilitated by better computer planning, and the computers allowed the machine to maximize developments that had been built into the machine, but there was no way to really plan with them. So the computer planning had to catch up with the components that were built into the machines. So the types of external radiation therapy are conventional fractionation, moderate hyperfractionation, and stereotactic body radiation therapy. External beam is done multiple daily doses over a certain period of time. Prostate cancer is uniquely sensitive to the higher dose per day. So back in the day, everybody got treated actually with about 30, 35 treatments with a total dose of about 6 or 66. That went up then to over 7,000, but again, at this lower dose per day. And this was done over 8 to 9 weeks. And unfortunately, that is pretty much how prostate cancer is still being treated across the country, in a lot of academic sites, as well as most private practices, because of course it is a revenue-based decision. And as well as that, people may not have invested in the technology or the training to get them to the next iterations, which are moderate hypofractionation, dropping down to 20 to 28, or going to SBRT, which is only 5 fractions. This has a lot to do with an investment of time into the planning and immobilization and imaging to be able to track what's going on with the patient, because these are very tight fields and you have to make sure that you're getting your target every day. So what actually is IMRT? It's the use of the advanced technologies to give the radiation with high precision. So you have different beams with different orientations coming in from all different angles, and they come in such a way that the high dose radiation is around the target, and you can shape the dose around the bladder and the rectum in the case of the prostate to keep those doses quite low. Stereotactic body radiotherapy is the form of IMRT in which you give a very high dose of radiation over 1 to 5 treatments. Again, using advanced imaging and delivery and immobilization. Many different platforms exist. So everybody hears about the CyberKnife, especially if you live in the New York area. But at the end of the day, again, the end result is the same. It's about the dose being delivered to a targeted area. So the Accuray CyberKnife is what everybody hears about. We're able to give the same type of radiation at a significant number of our VA facilities, and we do have VA facilities who have CyberKnives. So SBRT is now considered a standard of care for prostate cancer in the United States. It's supported by plenty of studies, and it's available in plenty of VAs and of our sites, and more are coming online. It is, however, a selection process. Not every patient is suitable for SBRT, just like everybody's not suitable for hyperfractionated. And we still have some people who the best treatment is the 45 days. So it all has to do with the individual guy. So if you look here, there's your prostate. It's a moving target. It moves during the treatments and it moves between treatments. So the margin around it has to be treated to ensure that you're getting all of it. You can't just be right on the money, because even within the seconds that you make a decision and you actually go to treat, there could be some movement. But whereas, like I said, when I started doing this, we were putting like 2 centimeters around it. Nowadays, we're talking in terms of less than 5 millimeters, 7 millimeters, depending on which direction we're actually putting the margin on. So this is a machine. It'll go around in all different, it'll do full 360. You set different angles, it comes in at different targets. It can even come in where you actually put the table at right angles to the machine, and it comes in with an angle kind of head to toe, if you like. And what happens then is this which looks like a tumor, who has a tumor or prostate that looks like a box like this, right? This is what you actually get. Okay, so this is, all these little silver lines are leaves, and these leaves are in the head of the machine, and those leaves are all coming in the shape that was designed for your treatment plan with the computerized treatment planning, with us drawing on the CT scan your prostate, and then that information gets transferred into the machine itself, and the machine then creates this aperture, which is what you end up with as the dose that the prostate gets. So the next thing, though, is how do you stop people moving around? Well, you know, unfortunately, we are treating a live patient, so they are breathing, so they are not immobile. We have to make up then for the fact you're alive. So the trouble is, you can see on this side, the tumor can move right out of the field that you planned. So we have different ways we've gotten around that. So this is what a plan would look like now for a prostate. And you can see on here that the prostate, let's say the prostate is the pink line. And then as you move out, the green, the blue, the orange, these are different dose lines as far as what dose of radiation is being delivered. The highest dose is around the prostate itself, and it falls off slightly around the edge. But you can see where the yellow line is, which is 50% of the dose, is going into part of the bladder, but not much. And it's going into part of the rectum, but the femoral heads, as you can see, are getting nothing. And if you were able to see all the cuts, you'd see that essentially the bowel doesn't get anything. But so what I wasn't able to get a picture of, but if you can imagine this little blue, the aqua blue that's next to the cross in the middle there, you can imagine that as a marker. Usually what happens is there are 3 markers put into the prostate gland. So there are 3 metal markers called fiducials are placed into the prostate in a small outpatient procedure usually, or we use something called calypso beacons, which is like a GPS system that we put into the prostate. They're not fiducials. So you put these 3 into the prostate, and if it's a fiducial, then you do CT scans before every treatment, and you actually line up then to those 3 fiducials to make sure every day that you're on target. If you have the calypso beacons, you're being tracked throughout the entire treatment. So if your prostate decides to have a hiccup and move outside what we planned, we will see that it's moved and the machine will stop and wait till it settles down again, and then we pick up where we left off. So it tracks it through the entire treatment. And this is done if we feel somebody moved or they coughed, we'll stop and we'll realign it again. So we're doing this as one way to manage people. They're also put into what's called a vac lock bag usually, which is like a styrofoam bag that kind of keeps your hips from twitching, if you like. Makes you aware that you have to sit still as well. But the main thing has to do with the imaging that's being done. The other thing is, and then on, as I said, for MRI guided, you don't use the fiducial markers because with the MRI, you're actually getting the MRI pictures throughout the treatment and you're able to see what's going on. And the idea is that you should be able to cut down the need for planning to be cut by about half if you're able to track it so closely. There are currently 4 sites that have been approved for this technology in the VA, and I imagine that there will be more. So then there's a device called a spacer, which is an injection that's put in between your rectum and your prostate. So you see in the diagram, the red area is showing where the rectum is up against the prostate. So then that would get radiation. But when you put the spacer in, it goes into that space. And so the radiation that would have gone into the rectum goes into the spacer. So that's another thing that we do to allow us to give the very high doses with a very tight margin and spare the rectum at the same time. And again, there are qualifications about who's a good candidate for these things. Then we have brachytherapy. I just wanted to mention that because we do have 3 sites in the VA doing brachytherapy, and if a patient wanted to come to a VA site, they would make accommodations for you. So brachytherapy is the most conformal because if you compare the image that says brachytherapy on it, all the dose is in the prostate. There's nothing really of any significance outside the prostate gland. as opposed to even the IMRT plan or an SBRT plan. There's always going to be some dose outside the prostate, because remember, the beams are coming from the outside in. So they are depositing radiation, albeit very little, along whatever track they're on, versus the brachytherapy is from the inside out. And there are two different ways it's given. One is low dose rate seeds, which means you're putting seeds directly into the prostate and you have the seeds with you the rest of your life. And the dose is delivered over 6 to 8 months. And it's usually done at one operative procedure, although there would probably be an ultrasound done prior to that in order to get the information they need to actually do the brachytherapy planning. The other method is that you have these catheters put into your prostate, and sometimes they're done as a one, but usually it's more like 3. So you go to the OR, you'd have the catheters put into your prostate, you come back to the department, you get treated in the afternoon, you go home because you don't have any radiation in you, you come back the next day, make sure everything is where it's supposed to be, get treated in the morning, get treated in the afternoon, pull out the catheters. And that's called high dose rate brachytherapy. And that is available through the Richmond VA at the moment. So almost all VA facilities are offering reduced fractionation treatment regimens. Care at a VA site, maybe work the extra travel time or staying at the VAH accommodations. A lot of our sites have hotels that are arrangements, or they have Fisher houses on site. We're typically doing hypofractionated treatment for 28 days or SBRT for 5. And we're doing this for sites beyond the prostate. Side effects from radiation are divided into acute. So that's within 90 days or late after 90 days. We're more concerned with urinary, bowel, and sexual side effects. Fatigue is another general acute side effect of radiation. Fatigue is kind of a hard one to put your finger on, though, because it can be related to androgen deprivation therapy. And it's also sometimes related with depression associated with the diagnosis, because after all the hullabaloo of getting diagnosed and getting set up and whatever, when you actually get into the treatment, then is oftentimes when it really hits you, and there are emotional issues. The acute urinary effects, they call it urinary bother. Obstructive symptoms are the most common, and they're treated with something like Aleve. Urinary medications such as tamsulosin. Urinary frequency can occur as well, and incontinence is extremely rare. So really what it is the radiation is inflaming the inside of the bladder, so it causes that urinary frequency or burning, or it's causing the prostate to swell, and that's causing you some of the obstructive symptoms. Foul effects are much less common than a bladder. Diarrhea-like symptoms can occur. Personally, I really did not see much diarrhea as an issue once we started doing IMRT. And if rectal pain occurs, you can use steroid suppositories. Again, with IMRT, and especially now using the spacer, I really have not seen much of that either. Late, you can have a less than 2 to 3% chance of significant urinary effects, so chronic cystitis, urethritis. There's about a 1% chance of a significant bowel effect, because the bowel slips down into all kinds of places, and everybody's body can be different. And if you've had surgery in the past, it can also mean that a piece of bowel might be stuck down somewhere. Cystitis, urethritis, and proctitis can be treated with hyperbaric oxygen if that was needed, which would be a very rare occurrence. And there's a very rare chance of a radiation-induced cancer. I'm doing this now 35 years or more, and I've never seen a prostate-related radiation-induced cancer. Acute sexual side effects are rare acutely, although men receiving hormonal therapy will notice immediate effects from the hormonal therapy. And the major long-term side effect is erectile dysfunction, which is also age-related. It's estimated to occur in about 23% of patients by 2 years after SBRT. In surgery, the sexual dysfunction has to do with them cutting nerves by accident or because they have to. In radiation, it's usually a vascular issue, so a lot of attention is paid to try and avoid those vascular bundles that are critical, but you won't necessarily be 100% successful. As you can see here, there's the neurovascular bundle, so That's the nerves and the vessels are in there together, and you're trying to stay away from these critical arteries. And they're saying that some low daily doses of sildenafil or tadalafil may help maintain the blood flow if taken for 6 to 12 months during or after RT. But remember, these are blood vessels like every other blood vessel in your body. So if you've got atherosclerotic disease in the rest of your body, the likelihood is you've got atherosclerotic disease in these vessels as well. I wanted to say that in the VA, we actually have a radiation oncology quality surveillance system, and it is something that has been developed with all these people on this list who are international experts in prostate cancer. It is unique to the VA. There's really nobody else in the country doing this, and it is our way of making sure that our sites are maintaining a high quality of care. We have them for all the major disease sites. Prostate was our first one, and we've recently just done an update of the prostate. There are 21 VISNs in the VA, 17 have radiation oncology facilities, a total of 41 radiation oncology facilities. And this can be one site. For example, in the New England VISN, there's only one radiation oncology site, which is at Boston, or you could have 6 sites, which is the case in Florida, I believe. So this just gives you an idea of where veterans live relative to where we have sites. So right now, this is just where they live. If you look at where the high populations are, Florida, Pennsylvania, Texas, California. In California, we have 2 sites. In Texas, we have 3. In Florida, we have 5 or 6. In Pennsylvania, we have 2. We're not really keeping up with where our veterans live. This is a map that shows you all the radiation oncology sites in the country that we have data on in the National Program Office. All the red ones are tier 3, which means that they're the ones who we don't feel can do much more besides palliative radiation. And that's why we're saying that the site closest to your home may not be the best place to go. The green ones are the better sites. And so if you look at where the green ones are, you can see there's a lot of gaps. And if you look at the state of Texas, you can see that for such a big state, it would be hard maybe to find the higher quality care close to home. But unfortunately, we can't say at the moment that this information is being used in these referrals. And that's something the National Program Office is working on with the Community Care Office. So I'd just like to thank you all for your service. It's an honor and a privilege for us to serve you in any way that we can. This is my email, and this is the email of the administrative officer for our office. And I would just say to you, if there's anything that we can do at any time to assist any of you, please don't hesitate to email me. I have come across veterans who've gotten radiation oncology treatment in all kinds of different environments as I've been in hospital with my father over the years. And it just concerns me about where some of our veterans are going and the quality they're receiving, because we can assist with directing that care if we're asked. So that's, I'm going to stop sharing and just open it up to questions.
So there's a few of us that have had radiation oncology, and both in and outside and through the community care network. But those, I guess, that haven't, let's open it up to questions. Anybody have any specific questions that they want to ask Dr. Kelly? I've got a few that I want to talk to you about. Tony?
Yeah, Dr. Kelly, thanks for the presentation. You mentioned external beam radiation and also brachytherapy. Is there an increase in the side effects when you get both, or does it not change anything?
No, there's not really. In the right hands, there shouldn't be an increase. Let me put it that way. Okay, it has to be done as a plan if you're doing them as a combined therapy, which is often used for higher risk patients. So they get about 5 weeks of radiation with external beam, which using IMRT, and which is usually a dose that doesn't cause a lot of problems. And then they get a boost. So they either get the boost at the beginning and then they follow with the external beam, or they get the external beam and then they get the boost. But has a lot to do with who's doing it, because you must consider the doses from both when you're coming up with the brachytherapy plan. But it shouldn't significantly increase any kind of side effects. And then, of course, most of those, one of the ideas is that if you do this, you possibly don't have to be on hormone therapy. And a lot of the problems prostate patients have are very much related to the ADT, but the data of how much of a difference ADT can make in people's lives in the long term is kind of worth putting up with it if you can. The other thing I should mention too is that one of the things that there's been a big change in has been that before, if you showed up with prostate cancer and you had bone mets, you'd be written off as, okay, you're incurable, put the guy on hormones, and when they fail, we'll move the next thing, you know, chemo or whatever. But now there's very much more push for the idea that, hello, there were probably guys 20 years ago who came in with prostate cancer and had bone mets, and nobody knew they had bone mets because the imaging wasn't good enough to show us the bone mets. And those guys all didn't die, and those guys all didn't go on hormones for the rest of their life. So there is much more of a push now to be aggressive if someone's in good condition and they come in with a diagnosis of prostate cancer with limited number of bone metastasis, then we would focus on giving radiation to those bone metastases in addition to the prostate. And in fact, there is a trial with Dr. Solanki with VA right now, which is testing that hypothesis. Somebody has their phone on or their mic on.
Yeah. If you're not talking, please be on mute. Thanks. Dr. Kelly, are you seeing, is there any data suggesting that the DNA sequencing and, you know, this, once we get diagnosed in the VA, now we're supposed to do this DNA sequencing. I think Dr. Redding and his team are putting these things together. Is that having any effect on decision-making or determination of whether you should or you're eligible for radiation treatment, or which type of radiation treatment?
So first of all, that's why I was looking for one of them to give the talk, because they're clinically active right now, whereas I'm in an administrative role. I can tell you that the radiogenomics you're referring to, I believe, is primarily in a clinical trial setting, and it has not been used extensively across the VA. What has started to make its way in has been the use of the Decipher test or Polaris. And that's what I was saying at the beginning as well, is that there's a lot of debate about how much difference any of these genomic tests can make. And of course, some of them are to decide whether you should get treatment at all, and some of them are to decide whether you should get aggressive treatment. So each one of them seems to has their own market niche. And again, that is what we currently have in a literature search done by the Evidence Synthesis Program, who will go through thousands and thousands of pieces of literature looking for randomized trials to support what the use of these are, so that we can start making a case for them being used in the VA. Because the other thing is that these tests are not readily available to every VA, and they're done through pathology. They have to be sent out, and if it hasn't been budgeted, there's not necessarily a guarantee that you'll be able to offer it to a veteran. So there was, I think, some money through Precision Oncology trying to get a certain number of tests done at a certain number of sites across the country, but it wasn't universal to every site that had prostate patients. So again, in that sense, you know, we have the perfect environment to really get the answers on a lot of these questions, but we're hindered by processes that exist for the utilization of new tests, et cetera.
Could we, is it possible that we could help by maybe pushing to get community care network funding opened up to be able to cover that kind of costing?
Well, I think most of these people are being funded, are being diagnosed within the VA. So the funding needs to go to that VA pathology department to send out the tests then to the appropriate lab, just as they send out other specialized tests.
Okay.
And this way, then you're sure where the result comes back.
Yeah.
And, you know, again, depending on who's managing the care in that facility. But I think just about every VA has a urologist, and the urologist should be playing a role.
Yeah.
Yes, community care, but community care, there is a role in here. We had put together actually a submission for the budget, which was not chosen to be submitted, for us to actually set up radiation oncology community care referral network across the country, so that we could be the people helping to coordinate this care outside the VA for radiation oncology, but it wasn't accepted. It was a pilot project.
Yeah.
So, you know, we can talk more about that. But again, you know, we're happy to sit down and develop clinical pathways with you too, because we're the people who are seeing the guy up front.
Yeah.
Has the elevated PSA, comes in then and has the biopsy. Where do you go from there? And this
No, I
is where
agree.
who needs what imaging, et cetera.
Yeah, and that's why we believe that you should have a role in it, and that's why I think we're fighting to get it across all of the VAs and to make it a you know, so that it has to be adopted, and that you have to have a role in it in the whole thing. The other question I have for you is in the community care network, since there's a shortage of radiation oncology sites within the VA, I mean, you don't match one for one all the medical centers. Does the blue ribbon panel have the ability, or do they have a charter to be able to verify yes or no whether a site that wants to be in the community care network is qualified to be in a site, or to be
they're not employed or recruited for that. So Astro, our professional organization, they assemble the blue ribbon panel to then put together the quality measures that we use for the quality surveillance.
Okay.
But our program office, we have within our program office where we have the wherewithal to know whether a site should be credentialed to deliver X treatment. So we are the ones who are able to say, yes, you can do SB. We had a situation recently in a state where we found out somebody was doing brachytherapy. And we found out that we didn't even know they existed. And they've been treating all these veterans. And then we sent them our questionnaire. So we're asking, okay, have you done this? Have you done that? So for example, if somebody wants to do stereotactic body radiation therapy, we actually have them get what's called a phantom, which for all the world looks like somebody's pelvis, okay, just chopped up. So you get this big slab that's a phantom that looks like a pelvis, and you have to do the plan on there as if it's a real person. And then we send that to Houston, to the Radiation Oncology Center. That is a quality assurance department for almost every clinical trial in the country, if not beyond. They then go through all the parameters that you would be looking for a good plan. And they come back and say, yes, you're qualified to deliver SBRT. You've met all the metrics. So we're looking to see if sites have gone through this A to Z testing of new procedures before they start offering them to the public. If you've got brand new residents coming out, they all have been doing this in their residency. But if you've been out of residency for 10 or 15 years, you didn't learn this in your residency. So you should be taking enough time and interest to take a course or, you know, go through the steps, figure out how to do it, because if you don't do it right, the consequences can be quite serious for your patient.
Yeah, sure. Okay, I saw some other questions. Fred, you got a question?
No.
Okay, Joe?
I do.
Go ahead, Joe.
You know, we've been talking about, and I'm trying to get kicked off some basic structure to having a VA support group.
Yeah.
And the function of that is not to go on to the specifics of a treatment, but where to find things within the VA, how to make your way through it. And it sounds like maybe I should be talking to Maria a little bit to see if we can structure something with that.
Yeah, we need to call their group up, and I think her name is Michelle. I have it written down.
Well, she's the navigator, but if it sounds like you're looking to be able to go onto the VA international or their VA national website and be able to open up a page that's directed to veterans with prostate cancer. Does that sound right, Joe?
Actually, even more beyond that, it would be the idea where vets and their families, for that matter, will be able to come in and say, you know, I'm trying to figure out everything from how do I get registered to where can I find a treatment, okay, or, you know, any of those kinds of things. And then from that, then try to direct them, or at least then find out what needs to be discovered so that we can advise them. And that's basically from either what other vets have gone through or what we can find out from experts like yourself.
Well, see, a lot of it's going to be regional. I can tell you, so I think there's a, like when I hear support group, I'm usually thinking of somebody who's been through treatment and is, you know, looking to talk to other people. And I have somebody who does that extremely well and is now actually probably going to be part of a national program that I'm wondering if they could actually open up something that was a national type support group that anybody could just join, because you can have hundreds of people on these webinars. But what you're looking for, I don't know that you can actually have somebody around the clock, like around able to answer those questions.
It wouldn't necessarily be around the clock, and we're talking about just starting off with a once a month activity, but we could get up to every week. But the idea is, you know, being able to point the vet to wherever they need to go to get that information, or in some cases where they go to find out more about a treatment. I'm trying not to do it in this program to do the typical support group of, you know, let's talk about how radical prostatectomy works, but more a matter of someone comes in and says, well, I'm trying to figure out, I got diagnosed and I'm not sure where I need to go, and you know, what kinds of treatments are available wherever.
So why don't you email me, Joe?
I already got that written down, dear. Yes.
Or why don't we see if there's something that we could test as even a weekly hour, just to test out, and then see where that brings us.
And Maria,
it might be something that we can set up in our program office that we could facilitate with a different service chief every week. And let's test it. I ultimately think it needs to be regional, because people are going to know like what things are in the region. Yeah. But as far as generic sort of like, what do you do next? We might be able to assist with that.
Actually, we can focus on it regionally, but the group that I'm also associated with that you know Mike's aware of is called ANCAN, and that is a virtual system that is beyond nationwide. So we can actually look at what's the best way to structure that, you know, and how to interact, because you know, the vets, I just know there's so many of them out there, you know, even the ones I've already talked to. It's like, I don't know where to go next.
Yeah.
You know, who do I see?
Right.
And that response or that question is becoming more and more prevalent as we gain a little bit more. It seems like we're getting a little bit more awareness as we start to reach out. And, you know, we're in the midst of helping 3 or 4 guys. We got, I mean, Maria, this is a guy, we got a guy in Panama as an example that's trying to get radiation treatment. So now, because we found out he can't get SpaceOAR there, we're trying to figure out where to send him or where to refer him to. And
not everybody does SpaceOAR though. I mean, like it's not necessary.
So he's going to come back up. He's a vet. He's registered at Tampa. I've told him, and we've all told him that, listen, you need to go back into Tampa and get the guys, you know, get your treatment there and talk to the doctors there. So that's kind of been the solution, is try to get them pointed back where the capabilities are. And we have guys, Keith is not on the phone. He's in another meeting, but he's been treated there at Tampa and knows very well the doctors and facilities there. So he can. I
find this very upsetting though. I find it very upsetting to hear that somebody's been given a diagnosis of prostate cancer and nobody gave them any direction of, okay, you have prostate cancer now, this is what we do next.
It happened to me.
I find that so
it happened
upsetting.
to Tony.
It's a lot.
But I mean, isn't the urologist making the diagnosis? Are they not having you back for a consult then to say what to do next?
Mine told me to come back in 6 months after I was diagnosed as high intermediate and with the PSA at 15.
Some of them don't know their way. They don't know their way around the system either. That's part of what we're trying to get organized so that we can facilitate that. You know, we're talking about, you know, in the 50 vets, we're talking about trying to get more education out to the vets and out to the docs. Okay.
Yeah, we definitely need to work on these pathways you're talking about, because I'm sorry.
This could be the link.
If you're a urologist who did a prostate biopsy on somebody and the biopsy came back as prostate cancer, you bloody well should know what you're supposed to tell this guy as what his treatment options are. And it should not be, hey, hello, you have prostate cancer, go back to your primary care doctor, good luck. That is not good enough.
Right, you're right.
My urologist told me to go research about what I wanted to do and come back and tell her. She said, I'm a surgeon, I can take it out, but go do the research and then come back in about 90 days and let me know what you want to do.
We have a lot of work to do, guys, because this is not how I have practiced medicine for 30 years. And I am very unhappy about this. This is very inappropriate.
Dr. Kelly, that's why we invite you to these meetings, right? Because we all have the same passion that you do, because that's what this group is all about, is that we've all recognized that there's a bit of a disconnect sometimes, and it's not always like, here's the one thing that we will say. You can get the best care possible for prostate cancer in the VA. I think hands down, and I think we have a lot of people here that would say the same thing. The problem is you have to know how to advocate for yourself or find others that have been through it, and you have to know how to direct your care through the VA. And that lesson is not there. Most of the guys in there are used to taking orders, and they do what they're told and they walk away. Well, unfortunately, there's where the disconnect happens, right? And so we get these calls now coming into us, which thankfully they're calling us. They're starting to call, and everybody on this call has taken those calls before, and that's that's what we're trying to do as a passion to this whole thing, and to actually understand that guys are out there that need this help. They need, because you can intercede at a very early stage in this disease and cure it, as you do it all the time. You have for 30 plus years. We have to get the guys to people like you. That's our job now, is to try to spread the word to get people like all of us to you to get it cured before we get into the metastatic state.
And that's what we're going to try to do with this support group, is try to have a focal point for somebody so they have a clue as to where to start, and whether or not it'll be coming out of VPCa or coming out of the VA directly or wherever, you know, because like you said, the VA is a great organization.
I can tell you right now, like right this minute, a brilliant resource for all your patients is the NCCN patient portal.
Yeah.
The NCCN patient portal, that book takes you A to Z through your whole diagnosis and everything, who you might talk to, what decisions you might have to make. It explains everything, and it's completely free.
Yeah, no, you're right. And we'll have another offline discussion about an application that we've developed that has that included in it. And it's that's something that we're pushing out through a number of sources, and I want to talk to you about implementing that. But again, I think Joe's right. We need to have a more regular source or a more engaged group or entity where people can come and find out that path, find that answer, right? And we tell them, I mean, the NCCN guideline is on our website, so they can refer that into the resources. The other, here's another argument that we continue to have with AUA and CCN, with ASCO. They've all come up with a guideline. They all claim they have the right guideline, but every one of the guidelines is slightly different, right? Mm-hmm. So, and I've told other leaders in the VA, Dr. Ramoni and Dr. Reddick and the other Dr. Kelly, Michael Kelly, that you have an opportunity to really make an impact on the world, or literally not just the US, but the world's prostate cancer issues by setting the standard. I mean, you have the largest integrated healthcare system. You have the largest number of guys that are doing this every single day under one auspices. So why isn't the VA setting the guidelines, setting the standards for care? I mean, because you have the largest registry, the largest database, you know the facts, and that's our push is that we want to rally around the VA and work together with you to make this known.
And not every vet knows how to interpret the NCCN guidelines either. Okay, they need help. You know, we're assuming that everybody's at a particular intelligence level, and some of the guys are at a lower level. And then I don't want them to get to the point where they say, "Screw it, I give up."
Right. No, I hear you. I'm with you guys.
Well, we all are. That's the point. We all want to work together on this. That's the idea.
Yeah, it's great. And go ahead.
If John had a question.
So another point that I've been getting 2 phone calls on is funding. Is it covered by VA? Mine was 100% covered by VA. I have another guy that's disabled as much as I am, and they're not covering any of his. So I'm not clear.
No, is he? What is he? I think it all has to do. I'm not the person, believe me, to ask about who's covered in the VA. My understanding is you have to be registered, but I would think most men your age are all. I mean, if you're all Vietnam vets, you should be covered. I think it's more a case. Now, of course, it comes back. My understanding is it's the same as private insurance. So whatever you currently pay when you go into the VA as a deductible, you still have to pay if they send you out wherever. Of course, if you've had Agent Orange exposure, you should be looking for that compensation. And a lot of them people aren't. And
John, I can talk to you. We're dealing with that, and I can give you some insight on where to send the guys to talk about that whole thing. So there's offices in every VA. It's down in eligibility where you can get the adjudication of who's paying and where they're not paying and that kind of thing. But I'll give you the insight.
Like even if you're if you come to the VA for radiation and you're someone who pays a deductible, they will want you to pay deductible for each radiation treatment. And we have tried to fight that locally by saying you should be categorized as a catastrophic illness, in which case then those co-payments would be eliminated. So that education needs to be out there too. Yeah. And I will tell you, just as an example, I'm pretty well versed on the whole community care network, as almost all of my prostate cancer care and all of my radiation has been done outside the VA. And it's all been covered by community care. And so the process is in place. And what you really have to know is what to ask for and where to ask it. And there's forms, there's paperwork you got to fill out, but there's paperwork in any other insurance company, right? So you just have to do it, and you got to get through it and find the right physicians and talk to the right people. But that, Joe, is a support group function that we can give to these guys.